Welcome, everyone, to our second seminar from the Prevention Research Center for Healthy Neighborhoods for this year. So I am very pleased to introduce Dr. Jin Kim Mozeleski. Dr. Kim Mozeleski is an assistant professor in the Department of Population and Quantitative Health Sciences and the Prevention Research Center for Healthy Neighborhoods at Case Western Reserve University School of Medicine. Dr. Kim Mozeleski is a social and behavioral scientist whose primary line of work examines tobacco-related health disparities among socioeconomically disadvantaged populations. Her work spans social, psychological, epidemiological, and community-based approaches to address health disparities. Notably, she was a contributing author to the 2024 Surgeon General's report on eliminating tobacco-related disease and death. She serves as the co-chair of the Health Equity Network in the Society for Research on Nicotine and Tobacco. She is the contact PI of the CONNECT-Pantries project, which is an NCI-funded R01 study. So please join me in welcoming Jin for this seminar today.
Thanks everyone for being here and for the introduction, Sarah, who is a PI of this R01 also. So today I'm going to kind of give you an overview of tobacco-related health disparities and the research that I've done to get us to this CONNECT-Pantries project and tell you a little bit about the design and where we are in the study. I welcome questions throughout, so if you have something that you're wondering about, then just let me know. Chat. All right. So, I like to begin with these explicit facts about tobacco use and their huge harms to society. And I think putting it like this really puts it into context to say, while some of us may think, well, smoking's been on the decline, it's not as big of a problem, perhaps, we want to recognize that it persists as a leading cause of preventable disease and death. Just looking at the annual healthcare spending and the number of people whose lives are affected each year, the scale of this is just an enormous issue. There's a wide landscape when it comes to tobacco. When we may think about cigarettes most readily, or maybe you're thinking about vapes and maybe that's not considered a tobacco product to you, but this is sort of the wide landscape of tobacco products. Of them, cigarettes are still the most common type of tobacco product. And we distinguish between what's a combusted product and a non-combusted product. And the combusted products like cigarettes, cigars, cigarillos, they are the most harmful type of tobacco product. And overall, while there is a risk continuum, it's that no tobacco product is safe. And another issue, a big issue to bring up, is that there's also a clear socioeconomic gradient in tobacco use. And so this is a snapshot from the most recent figures at the national level, where you can see a really clear socioeconomic gradient, and this is by the income to poverty ratio. And this disparity has been existing for 40 years and has persisted during that time. While the numbers have shifted, the pattern has been remaining this way. And so it's a huge concern, and this is a major interest of mine, is to address these socioeconomic disparities in smoking. So you may have heard tobacco is not an equal opportunity killer, and that's absolutely the case. I here like to emphasize that we see these disparities not because there's a difference in people wanting to quit or trying to quit. So when we look at this from the national figures in terms of the interest in quitting and people trying to quit, there are not socioeconomic disparities. And I want to keep highlighting that. Most people who smoke want to quit. Many try to quit each year. So keep that sort of major statistic in mind. But one reason why we do see a socioeconomic gradient in smoking has to do with who is able to quit smoking at the population level, who's been able to successfully quit. So this is a fairly simple metric called the quit ratio, which is the proportion of people who have ever smoked who are now former smokers. And you can here see that the quit ratio also has that socioeconomic gradient. So based on income to poverty ratio, more people in the higher end of this income to poverty ratio have quit compared to people below 100% of the federal poverty level. As I mentioned, overall smoking prevalence has decreased, and this is a figure I sort of show to illustrate all the things that have happened to do this at the population level. So the highlighted red box is when the 1964 Surgeon General's report was released. It was the very first report that has come out, and it highlighted there that lung cancer, that smoking was a cause of lung cancer. And so with that report, we started to see declines in smoking. In 1964, that was also when the smoking rate was peaked at the highest in the US. So that was about 45% of the US population, but at the time they were just looking at that among men. And then you can see sort of how different policies and various public health movements kind of started to bring smoking down even more. So things like banning advertisements on TV, for instance, and additional Surgeon General's reports coming out over the years. So we see this nice decline, which we as public health professionals would like to see. But along with that, it has gone down overall in the population, but not equitably. So with this decline, the disparities have increased. This is a different snapshot where you can see kind of by level of education as a proxy for socioeconomic status. And this is what some scholars have called the inequality paradox, where you see an improvement in something at the population level, but a population level improvement doesn't necessarily mean equitable improvement. So we see, as I have said, 40 years this disparity has persisted. You may also wonder, if most people want to quit and they try to quit, why don't they just quit? Why, I know so-and-so who was able to quit, and we may have some ideas as to, why is it that people aren't able to quit? And so I want to highlight here that there are these social and structural factors that perpetuate tobacco use in certain populations, such as you see from that quote, this is from the Surgeon General's report. So it's more than beyond an individual level treatment, although absolutely anyone who wants to quit and tries to quit should be given access to evidence-based treatments. But along with that, it is a much larger issue. And there have been these national reports devoted to understanding and trying to tackle this problem. I show this photo quite a bit in my presentations, and it's a NBC News article from a few years ago. You can see the headline there has to do with homelessness and housing, but the piece that I like to highlight is this caption down below that you may not be able to read, but it says, Bobby Rojas smokes in his tent amid a homeless encampment on Skid Row in Los Angeles. And the reason that this photo really sticks out to me is that it shows the inextricable links between smoking and poverty. That's like a clear illustration that we see this at the population level. And you may also think, well, cigarettes cost $10 a pack or so. And so people are spending money on cigarettes, and all of that to say that these are social and structural issues that perpetuate these health disparities. And so we need to pay attention to this. So related to that, one aspect of poverty that's really been linked to high levels of stress is this experience of food insecurity. Here's a definition that the USDA, or the US Department of Agriculture, uses in defining food insecurity. And then on the right, you see the trends in population level food insecurity, over the years since they've been measuring it. And you'll notice from 2007 to 2008, there was this sharp incline that had to do with the Great Recession of 2008. It took probably 10 years for that number to kind of come back down to pre-recession levels. Many of us were kind of surprised when we saw this to see if you notice the COVID years, 2020, there's not necessarily that increase that we may have expected based on what we were experiencing during that time. And I'll show a little bit of data related to that on the work that we've done. But then you see shortly thereafter, this increase, sharp increase, that's due to many of the pandemic protections having gone away during that time. So you see this kind of trend in food insecurity that aligns with what's happening at the national level. I wanted to just show this to kind of disaggregate that 13.5% by the income to poverty ratio. So it does disproportionately impact people who are under poverty, not everybody, and also it impacts people who are above poverty as well. But there is a close linkage there. And we know from the literature that food insecurity is well linked to many poor health outcomes, mental health and physical health outcomes, and the management of those conditions as well. I wanted to make a few points about food insecurity that people may not recognize just off the bat, which is that when you hear food insecurity and you hear that 13.5% of the population are food insecure, it's food insecure at any time in the past 12 months when they measured it. And yet food insecurity tends to be more episodic than chronic, which is that it goes up and down throughout the year. It fluctuates, and it fluctuates along with specific kind of times that you may expect. Like for instance, if a household that has children and their children are out of school in the summer or something like that, we'll see those patterns, right? And it's actually this episodic nature that I think really contributes to the stress of food insecurity, because it is that uncertainty of when is it going to happen. The fact that it happened once over the past year is an important indicator of food insecurity, because now you've had that experience, and so you may be anticipating it, but also it's that cycle. And so that cycle contributes to hunger, which is very low food security, is defined as like when food insecurity is so severe that your food consumption is cut. It has disrupted your eating patterns, right? So there's a cycle of hunger with, not eating enough when there's not enough food, but when there are times when there's enough food, there's an overconsumption pattern. And so that can then contribute to poor management of like diet sensitive chronic diseases. We know from the literature that trade-offs are common with food insecurity. So many folks who are food insecure and maybe dealing with diabetes are having to decide, do I pay for medication this month or do I pay for food? So that's an example of a trade-off. I'm just going to go through a few slides to give you the high-level overview of what I've learned about this, the link between food insecurity and smoking over the years. That'll then kind of lay the foundation for sort of how we got to the work that I'll be presenting on. So you may or may, I didn't put this explicitly on these slides, but you may or may not have heard that, smoking and stress are very much linked. A lot of people smoke to deal with that, the stress. Food insecurity is a major stressor, and there are these kind of conceptual linkages. But to just give some numbers, I found, my work and others have over the years found that it's about a third to a half of US adults who are food insecure are also smoking cigarettes. And we sort of see this dose response relation. So as the severity of food insecurity goes up, so does the prevalence of smoking. I highlighted this study down here. This is a study that I did during my postdoc fellowship. And this is a sample of women who are experiencing homelessness. And even in this group, we saw the same pattern with the severity of food insecurity and smoking, either the prevalence of smoking or the number of cigarettes. We also found, in some work that I've done, that population level changes in food insecurity and really these shocks that may happen at the population level impact. So we see corresponding changes in tobacco use. So this was a paper I did that looked at kind of the time in between the Great Recession, kind of just using two data points. And this is an actual really cool data set, I'll have to say. So if anybody's interested in learning more, I'm happy to talk your ear off about it, because I had an entire career development award like getting into this data set. Why was it so valuable? At the time, it was the only nationally representative household data set that measured food insecurity more than once. So, and now since then, there have been many more, but at this time, and it's the longest running household survey worldwide actually, and it's out of the University of Michigan's ICPSR. So it's a fantastic data set. And we found that the changes in food insecurity, or I should just say transitions, because I was looking at 2 time points, corresponded with changes in or lack thereof in smoking. So to give an example, in the first time point, in a group of smokers, among those who stayed in food insecure, they were more likely to stay smoking. Among non-smokers at baseline, when they became food insecure, they were more likely to relapse into smoking. And so we saw this significance at population level. And then we did some work during the pandemic. I showed you how like in 2020, it didn't quite move, but according to the USDA report, and this one, we really tried to uncouple it. One additional thing about data set is the 2 studies on the right use a data set called the Understanding America study, and that's out of University of Southern California. So cool because they measured these factors every 2 weeks in a representative sample of the US. And so that was a treasure trove of important data that we didn't have before.
Jen, is that only during COVID or they do that all the time?
They do that all the time, so you can even link it to prior years. I think in COVID, they upped the data collection frequency to every 2 weeks. Now it may be monthly or it may be even annually, but they have, it's the Understanding America study. So, these are just really neat data sets to kind of explore your research questions around. I think when Dr. Koopman Gonzalez was introducing me, there were all these kind of different methods that I use. And as during my postdoc, and my first few years as assistant professor, I was like, let me get my hands on like every data set that I can to examine this from like all different angles. And so that's sort of how I came to draw these conclusions. And that's just a plug to our first year PhD students. I'll start with this top left, which is from 2020 to 2021. You can see the measurement from April to March, and the shaded part is kind of the error bars. What you'll notice is that the prevalence of food insecurity was really high in April, and then there was a kind of steep drop off. What that was showing is that you may remember April 2020 when things were shutting down, right? And we didn't know what was happening, like what was going on. People were feeling food insecure because the supply chain dynamics, like maybe the store shelves were empty or they just couldn't go to the store. Right? Like those things were happening. So people answered those questions to reflect that, right? So it was a steep drop off. Now, when we use latent class trajectory analysis here to look at the trajectories and to identify the various classes, what you're going to see is there are these groups here. This is a group that just stayed food. There's a group down here with this open diamond that's kind of remained food secure the whole time. But you'll notice like these 2 blue ones that we called it kind of initial shock, where it was like kind of the initial shock of the pandemic made it high. But it actually, when you look at their demographic characteristics, really resemble the people who are food secure, right? And among this, the ones to pay attention to are just like, there are different patterns within, and there's some whose food insecurity is sort of worsening over time, right? And so in the subsequent paper, we had then mapped this onto patterns of smoking and to find that, that particular pattern of food insecurity, for example, was associated with a greater number of days that somebody smoked compared to staying food secure. So these are kind of ways to look at how variations in food security are also impacting cigarette use behavior.
Sorry, before you move on, I have a question. Can you explain the differences between like the open and closed circles? Like became insecure 1 versus became
Oh.
insecure 2?
Yes, so we had used an analysis that then identifies how many of these patterns fit the data, right? And so we thought that it was like became insecure or became secure, like you see it based on the pattern, though it's slightly different in terms of the intercept and the slope, right? Those are just arbitrary numbers that we gave to label this in that way.
Okay, so you are essentially saying that there's 2 separate groups within each of like became insecure or
There are
Ring.
3, 6, 7, 10 groups total across the population.
yes. But I guess like I guess I'm just confused by like the 1 and 2 and then like the 2 and 3.
There's no like ordering to that really, it's just a label that we
Oh,
gave.
okay.
So we could have named it something else like started at a low intercept and then had a steady slope or so,
Okay,
it was just these arbitrary terms that we
Okay.
gave
that makes sense.
based on the overall pattern that we're seeing. And sort of the last thing that I'll say about like the body of work on this was that, smoking and food insecurity, they can worsen one another in this kind of complex reciprocal cycle. So all of this went into a Feeding America report in 2020, in which they did, acknowledge that smoking was one of the drivers of food insecurity or correlated with food insecurity, I should say, in citing some of this work. And this paper in the middle was a scoping review paper that I did in which I actually published a conceptual model of what was happening here based on the literature. So all that to say, what now? So given this, and maybe, I probably don't have to go through all of these factors about Cleveland, but I will. It's really the level of the community in which I think you can have a lot of impact, taking all of these national level findings, right? And applying it here. So Cleveland, Ohio, you may or may not know that has a high rate of poverty compared to other US cities. It's often the first or the second in the list, neck and neck with Detroit. And while, Cuyahoga County as a whole isn't considered one of those persistent poverty counties, we know that there are census tracts within Cleveland that are persistent poverty. And so that, as you know, are associated with all sorts of lack of access and poor health outcomes. And we know that food insecurity in Cleveland is higher than in Ohio, which is higher than the US as a whole. We, up until just earlier this year, were citing numbers that the prevalence of tobacco use in Cleveland is 36% or so. And Dr. Stephanie Pike Moore conducted the Cleveland Health Survey earlier this year. And you can sort of see how those numbers have shifted. So it went from this kind of mean of 36, 37, and now it's at about 20%. I think it was 19.5. But what to notice here is that it's also not going down equitably for these groups. So you see that decline is smaller than the decline in the white group. And then this one, you'll have to ask, Stephanie Pike Moore what's going on, because I don't quite know, but this was offset, like this decline in cigarette use was offset by an increase in cigar use too. So these are kind of things to really look out for. And cigars, by the way, are that combusted tobacco product.
Sorry, is this percentages? Or
Yes,
different?
yes. Okay, so that kind of brings, all these questions about how could we reach populations who smoke for tobacco cessation? What I didn't say here is that there actually are a number of evidence-based methods, evidence-based treatments to be able to quit, and those have existed for many years, right? But it's clearly not reaching the populations equitably because we still see these disparities, right? So the overall question is, where could we reach populations who smoke for tobacco cessation, knowing that most people want to quit and they do try to quit? So that question is about the reach. So through the work that I've done over the years, we came to recognize that Well, many people who are food insecure, they tend to visit food pantries for food to make their ends meet, and they also do use them on a regular basis. And people tell us it's a trusted and familiar place that's in the community, where people go for help. They're used to going there. We know from the research that there are models of health promotion in food pantries, like doing kind of nutrition education or other types of chronic disease management. And then overall, we know that pantry organizations, they do care about the health and well-being of their community members. So kind of putting all of this together, it gave us this novel venue to try to reach people for tobacco cessation. This was work that was published in 2024, but took years to do really. And it started with doing this in the pandemic. So prior to even proposing the study that I'll be telling you about in its details, we ran a pilot. And so this was during COVID, where we conducted needs assessment surveys with people who use food pantries to sort of estimate how many people are using tobacco and interested in quitting, what have they tried, what are other health and social needs. Based on that, we got together some virtual resident advisory focus groups, as we had some kind of model of doing an outreach of tobacco cessation in food pantries, but we wanted to get their input to say, well, we're thinking, let us know, what do you think about this? And they gave us some great feedback that then informed the way that we did this pilot smoking cessation outreach in food pantries. And we went out into food pantries in 2022, so put on our masks, went into the food pantries, maintained physical distancing. I know Maddie's nodding her head since she and I were out there quite a bit. She did a lot of the surveys and whatnot as well. And what did we learn from this? We found that in this sample that we sampled, it was about 31% smoking prevalence. And these numbers in terms of people wanting to quit and trying to quit are even higher than what we find nationally, right? But when we asked about a number of evidence-based treatment use, including the quit line, which I'll explain what that is in a little bit, it was that most people, they'd never heard of the quit line, or they've never tried the quit line, even if they had heard of it. So this identifies kind of a gap that we may be able to address. So what is the tobacco quit line? If you maybe heard of like 1-800-QUIT now, that's the tobacco quit line. Every state, DC and territory has their own state quit line. So if you call 1-800-QUIT now, it'll route to that state's quit line. Available in Spanish and multiple Asian languages for the callers. One thing that we know from the research is that Quitline is high reach because you just need to have access to a phone. It's a toll-free number, but tends to be this lower awareness that the Quitline exists, and then awareness is going to then impact use, right? So this is a gap that we can address. You see some information about the Ohio Tobacco Quitline, which is what we are connecting or linking our folks to. It's you see the range of services that they offer there. In this 2024 Surgeon General's report, Eliminating Tobacco-Related Diseases and Death, one of the conclusions was that quit lines are effective in increasing access to cessation treatments, particularly when the promotion and services are developed, delivered, evaluated with attention to reach and relevance to these groups. So this is sort of how it feeds into the work that we're doing. Okay, now I'll tell you about this project, which we're in year 1 of 5 right now and towards the end of year 1. We're calling it CONNECT-Pantries. You can see the range of community partners we have below. And the overall goal of this work is to leverage a community-based food pantry to connect residents who would like tobacco cessation services to those services using this model called SBIRT, Screening, Brief Intervention, and Referral to Treatment. I'll say a little bit more about that in the next slide. And it's really to improve the reach, the use of the quit line, and overall the impact that the quit line can have. Right. So in this project, we're really emphasizing the community engagement part and this real world, running this trial, running this study in real world settings. So it's a pragmatic randomized controlled trial. Okay, a little bit about SBIRT, the screening brief intervention and referral to treatment. So we are using this model called Ask, Advise, Connect. And it's an evidence-based clinical method that can increase access and use of the quit line. So you see where it comes from is we have this kind of 2008 clinical practice guidelines for treating tobacco, where if you go to the doctor's office, they sort of follow this protocol. You know, ask somebody about their tobacco use, advise them to quit, assess their readiness to quit, assist in getting them linked up, and then arrange for follow-up after that process. But they then took the 5 A's and created what's called Ask, Advise, Refer. So asking about tobacco use, advising, and then the referral, right? And so AAR was a predecessor to AAC, which is a proactive connection. So rather than burdening the person with here's information to quit, wanting to quit now, it's rather let me send the information directly to them and make that connection.
I just want to make a comment, if you go back, as they're building models, sometimes you realize the term that you use wasn't right for a variety of reasons. So AAR to AAC, that is common in building out these, that you have to refine. It may not be perfect, and then you apply it, and then you have
Yes, exactly. Because AAR was at the time an innovation, right? And then they realized actually, we could make this even better. So I'll show actually some figures from research about AAR versus AAC. This we created for our research participants actually, because we're co-designing this AAC process to work in a community food pantry. And so we use this to sort of like walk them along what actually is AAC. What is that, right? So if you go to a doctor's office, maybe you're checking in at the front desk and then you first see a medical assistant who takes your weight, blood pressure, right? They may then ask at that part, you know, whether you use tobacco, yes or no. Then that information is entered into the electronic health record. We sort of write down, you know, for here, just information's sake, you know, how long does it take? Because people then ask like, well, this sounds like it takes a long time. Not quite. The next step is then to advise the person to quit using tobacco. And this work, the example statement there, I'm highlighting this because while that seems really simple, like as a member of your healthcare team, we strongly recommend that you quit tobacco. That work, Sue Flocky, who used to be here at Metro Health, but now is at Oregon Health and Sciences University. Her work has used that statement, and it took a while for them to land on that statement because it's something that the medical assistant has to feel comfortable in being able to say, right? You can't, if you're uncomfortable saying that, or maybe that medical assistant is smoking themselves too, there's kind of things to be aware of, right? So it seems like a simple statement, but they did a lot of work to kind of get to that statement for their study. So that's an example. They note that the advice was given. And then from there, they ask if, you know, do they want the connection to the quit line? If they do, then they kind of send the referral directly using the electronic health record or other methods of sending that referral directly. And the bottom right, you know, the interaction may not take long, but doing the actual paperwork, or if people have questions, you know, so that there's a range in how long this may take. And we use this to like really walk through this process at a doctor's office with our participants. Okay, I'm going to show a little bit about the original Ask, Advise, Connect studies that were done by Jenny Vidrine's group, and they were both published in 2013. And so these were both done in healthcare settings using a fairly large sample. The first one, I think, which one was? One was over this one, the one on the left was over 40,000 patients. The one on the right was around 110,000 patients. So it was across these healthcare systems in which they tested AAR versus AAC to look at the effectiveness. Okay, they use this RE-AIM conceptual framework, reach, effectiveness, adoption, impact, and maintenance, which is a framework by Russ Glasgow and colleagues. And in this study, what you're seeing is the reach, which was the number of people who were connected to the quit line in AAC was 14.4%, whereas the effectiveness, they define that as not only did you get connected to the quit line, but did you enroll in quit line services? Did you then say, yes, I want to enroll in the counseling? So that was 68.7%. And then the actual outcome was on the impact. So it's the product of those two that shows 7.8%. Okay. So I just put the color coding there because I know sometimes this could be a little bit difficult to digest. But if you look at, let's say, the AAR column, and we'll look at this for this first study up here, Ask Advise Reach had a quit line intake of 0.6%. And this is, recall that this was over 40,000 patients in this study. Though Ask Advise Refer in terms of the enrollment was 100%. And so what does that mean? Well, if you go to the doctor and they say, do you want information on smoking, and you take that information and you call them, you actually go out of your way to call them, then that means you are highly motivated to enroll in these services, right? So when you look at the actual numbers, it's like 5 people maybe called and enrolled, right? And so if you take the product, it's a very low impact number. So these are the things that kind of set the stage for the work that we are doing and the hypotheses that we're drawing in our work. So our work has 3 different aims. Right now, we're sort of finishing up aim 1, which is we're adapting this AAC method so that it can work in food pantries, and we're using a co-design process to do so. And with that, we're engaging with stakeholders using focus groups and with both food pantry patrons, so people who visit food pantries, as well as people who work at a food pantry. Then we're doing a town hall event where we're kind of bringing what we have heard to finalize what we think is a AAC model that can work, or what we're calling community adapted AAC. Then starting early in Q1 of next year, we're going into the RCT portion where we're running this as a 2-arm. So comparing AAC pantries versus Ask Advise Refer. And it's a pragmatic cluster RCT across 20 pantries. It's pragmatic again, well, I didn't say it's pragmatic because it's the real world setting in which we as researchers are not necessarily going to be at the pantries doing the data collection. We're trying to embed this into the practice of the food pantry so that it is just how they operate. And we're running it as a cluster RCT, as we'll be matching food pantries so that we can have a little more confidence that we can isolate the intervention effects. And then aim 3 will also take place starting next year, where we're going to be tracking the multi-level contextual factors that impact this process, AAC in food pantries. I'll say just a little bit about that, and then point you to Dr. Sarah Koopman-Gonzalez's talk next month, where she'll be talking about implementation science and aim 3. Another piece of our work that we've done is there's a research team, as Aviana's smiling as she sees herself here. There's a research team, as with other studies, but we also have what we're calling the design team. team. Originally, in the grant proposal language, I think we call them like a community advisory or community engagement board, community advisory board, but they're actually doing a lot more than that. And they're really part of the research design. So we recognize them as members of the design team. We just had a meeting this afternoon in the design studio with the design team in preparation for next week's town hall. So they help us even formulate like how to ask the question so that we can get the answers that we may need. And they help shape, today we're looking at these like what we're calling like journey maps, like how do people walk through a pantry? And they're like, we got to cut, this out because it's too much words. Can you cut down on that and make this a simpler process? So those are examples of how the design team's been working with us. And we have different representatives of the design team.
Quick question, do your design team members, is there a compensation for them to be involved?
There is compensation for them to be involved, yes. Are you asking for how much?
Yeah, just, I mean, I think just for this, because this is about, our focus is community engagement this week.
Yes.
So
Oh,
how do you
got it.
compensate people and like, how did you make those decisions?
Yeah, we wanted to really compensate folks fairly well because it's an involved process that we're asking for. And these folks are very busy people, whether they're leaders of organizations or food pantries or even, leaders of these community organizations who are taking their time to come here. So we, we drew up a charter that said, these are our roles. This is what we're gonna do, what we promised to do, and we're gonna ask of these things for you. And so over the year, I think it's about $1,800 per member that's spread across multiple of these design team meetings. Yes.
How did you choose them? Was it like an open call situation or did you reach out specifically?
We reached out specifically to folks, especially for instance, we have residents who are on the design team. So people who aren't affiliated with a community organization, those are people that we have relationships with from prior studies and thought, we think they're going to give us good feedback related to what we're doing. So that's what we did. And then for organizations, like for instance, there's a member of the Greater Cleveland Food Bank on our design team, but it's a different person, or that person has a different role than on the investigator side. So they bring a different perspective.
How much do you think is like a person that is part of the research themselves? Do you think that they should also contribute to the research designs in ways? Like, is that?
Yes, we think so. And that's I guess that's what I meant. I should have clarified when I said residents as part of that. These are folks who are like lay persons of the public who were our research participants in the past and have talked to us extensively about their experiences. So we wanted people, at least for residents, who had experience in using tobacco, right? So without that, then we're just kind of talking to people who've just imagining. Is there anything else you would like to add to that? Dr. Koopman-Gonzalez kind of runs that piece.
So in our focus groups, we also are supplementing the design team with additional information through the focus groups in the town hall, which includes individuals who go to pantries or work at pantries to provide additional viewpoints to get that viewpoint in. And then the design team takes those results and keeps working with it.
Thank you. Thank you. Here, you see it sort of down here, so you may miss it in red, but this is when we say how it works at a food pantry. This is not the final product. This is just something that we created as a tool to discuss how AAC could work at a food pantry, just to get the conversation started in one of our focus groups. Because unlike a doctor's office, it's sort of, it's not a medical setting, right? So who at the food pantry should ask? How should they even introduce the question? So it isn't just like, oh, you're here for food. Do you smoke tobacco? Right? So that we can then let folks know the information that they need, right? How do we document this, given that we're not working with electronic health systems, right? And what should be that sort of example advice statement that's different, going to be different from a food pantry, medical setting. So here's an example statement that we came up with just to get the conversation started. And it was, as someone who sees you and cares about you, smoking may not be the best thing, blah, 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 right? And in our focus groups, we heard a range of responses around that. Some people were like, yeah, I like to feel cared for. Other people were like, you don't care about me, you don't know me, don't say that, right? So, you know, we know that that statement is something that has to be modified. And we also, you know, how should we, again, documentation, and then also making that connection, because in the electronic health record, they're all integrated. So you click that button, it goes to the quit line. The healthcare system can then see, okay, this person was connected, whatnot. But it's different in a community-based setting where we don't have that kind of infrastructure. Just a little bit about who came to our focus group. So we did these in different rounds. So for round 1, round 2, and then it's the town hall. But you can see in round 1, we had 40 participants across 6 different focus groups. And the idea is that the same group comes to the next round 2, because then we're reporting on what we learned in round 1 from them. They have an idea of what it is that we're trying to do, and then we ask the next set of questions. And you can see we had 16 pantry workers and 24 pantry patrons. All pantry patrons had to be either current or formerly smoking. So 75% were currently, and then for the workers, we didn't use that as a criterion. The number of unique pantry sites represented, I think, is important, because among the 16 pantry workers, they were from 14 different sites. And then the same with the pantry patrons, you see that spread. And, you know, why?
June, quick question, in your study design, are you limiting to pantries that won't be in your study for the design phase?
Yes, for the design phase, that's the
Like in
idea.
your RCT, so these 14 won't be eligible for the RCT?
Yes, that's our idea. It may not align perfectly, but that is what we were doing from the beginning.
And how did you broach that with them, like from a community engagement perspective? It's like, help us build this, but you're not gonna be eligible to test it.
That's a good question. I'm not sure if we were like explicit about that part, where we,
Well, for the design team members, we are explicit about
yes,
that.
for the focus group participants.
For the piece about it, the workers versus the patrons, because patrons go to so many different, you can't quite fully control
Yeah.
that. And that's one of the acknowledgements of whether or not they will participate in the RCT or not. Still may have had experience with
Yeah.
those because of the way folks move around the space. So it's not quite controlled, I would say.
I would say yes, and then the other thing we can think about is that food pantries can, as you know, vary widely in sort of how many people visit each month or their hours of operation and such. But we also know that there are like really small food pantries who kind of have a different kind of a workflow. But that size food pantry is probably not going to be feasible for our RCT, because that's based on a power calculation, right? So we're going to kind of eliminate those really small food pantries, and yet they can have a lot to contribute about the process. So that's also how we kind of thought about it too. I don't need to go into each of this, but it's to show that like every food pantry is slightly different in how people pick up food, whether it's drive-through, what the physical space is, which means like what happens at each place. And so that's why it's important to kind of have the breadth of food pantry representation in our focus groups. So in round 2, we had 26 of the 40 participants come back. Interestingly, we just presented this to our design team. The attrition there was among the food pantry workers and not the food pantry patrons. The food pantry workers, they fully intended to come, and at the very last minute, we're calling, I'm so sorry, we can't make it. That just goes to show how busy a lot of these folks are. But in round 2, what we did was, we re-invited the same group. And I'll say that these were separate groups. We didn't put pantry patrons and workers in the same group. These were conducted separately. We started by kind of creating this sheet to be like, this is everything that we've heard from the suggestions. We heard you. There are also things that we heard that we just cannot do. For instance, having a doctor on site at the food pantry, having a health professional on site. That's not going to work for X, Y, and Z reasons. So we created this first to report back. And then in the second handout, you see that folks had a lot of questions about the quit line that they wanted to know. And we wanted to then say, okay, this is, we want to let you know that we heard you and here's some information. So then in round 2, you see Dr. Koopman Gonzalez here running part of the focus group. And we did this in kind of an interactive style, based on everything that we heard, we created these like pantry maps, because not every pantry is different, but we try to kind of generalize it, and it fit into these like 4 categories. Like this is where somebody comes, this is where they wait, so on. And then we had participants kind of put sticky notes as to where different pieces of this intervention could be happening. And so the transcripts we created a draft of the journey map, which we got the design team feedback today, and we're preparing for the town hall that will be happening next week. Oh boy, this is a busy framework or busy slide, but it's important for the framework. It's called the Frame IS, a framework for documenting modifications to implementation strategies in healthcare, because we collected all that focus group data, right? What are we doing with it? How are we analyzing it, right? So we're doing this. This gives us a way to analyze and what we're coding in each of the transcripts. So Module 2, what is being modified? This one, content. Okay, and I'll give an example of that. Module 3, what is the nature of the content evaluation or training modification? So we're using this as the framework to go in and code our transcripts. So for instance, and what is being modified, right? In our transcripts, when we see that there's a discussion of the specific steps of the AAC, then we code it as that code. And so we're going through this in a very systematic fashion. And I think Sarah might be talking about this more next month, perhaps. She's leading this. She's leading this process, but I just want to be clear that we're using a framework to document these modifications. And that in itself will be in a word paper. I said the first bullet point, and then what's going to come out of this is this prototype. So co-design, it leads to this prototype, and the intervention that we believe will fit the needs of the pantries in different settings. So they may look a little bit different at each site, but the core elements will be consistent, like asking about tobacco use and so on. So that's going to then yield this implementation toolkit that could hopefully be applied to other pantry settings. And then data collection procedures, I'll say just a little bit and just kind of speed through these since I'm at sort of the end of the time, closing in on the hour. So aim 2 is to run the RCT, the cluster RCT portion. This just gives you how we're measuring the outcomes, the reach, and the effectiveness. So what's going to be really interesting for this is that as a pragmatic study, I say there's exciting opportunities and interesting dilemmas. The reach is the number of quit line intake calls that were completed over the denominator of the pantry patrons who use tobacco, right? But this number comes from 2 different sources. So the top number will have to come from the quit line. The bottom number comes from either the Greater Cleveland Food Bank or the food pantries themselves. And so then we're combining that to estimate the reach. For the effectiveness, it's just the quit line numbers. But interestingly, as RCT, it's actually considered non-human subjects because we're only looking at aggregate data. Aim 3, so this is to kind of look at those multi-level contextual factors. I believe Sarah will talk more about this next month, so let me just highlight that real quick right here. Join us if you want to learn more about implementation science, but kind of going back to this, these are the methods in which we're going to track, how is this working in real world settings? Like what are the things that sustain this, or what are the characteristics of pantries that aren't able to adopt this. I'll say a little bit more, like one thing about the external environment, which is kind of what's happening collectively at the community level, even at the national level, that could be impacting any aspect of this. And if you know anything about 2020, it's to expect the unexpected, right? And so these are really recent articles that I've pulled. It's December 5, 2024. The one in the middle is November 2024. The one on the right, June 2025. It's that trend that we don't want to see. Like bell bottoms may come back, but it seems like smoking is trying to make it come back, right? And so we're sort of starting to see this in the popular media, while the federal cuts to funding have been just awful, not just to like the NIH piece, but in the CDC, they have the Office for Smoking and Health, which is who actually funds the money to the quit lines, and all of these campaigns that have been sort of wiped out. Though you see in the cessation infrastructure on the right, it says 1-800-QUIT-NOW is still active. We're keeping our fingers crossed. States differ in how much they rely on the federal funding for the quit line. Ohio is a smaller portion than other states, but like for New Hampshire, for instance, their quit line funding is pretty much wiped out. So we actually don't know if you're in Ohio and you call 1-800-QUIT-NOW, what happens, you know? Yeah.
I'm sorry, I don't know if you explained this, but like, what is the difference between calling like the 1-800-QUIT-NOW to the state quit lines? Like, aren't they both quit lines?
They're all quit lines, but that number is just like a central number that routes you to your state's
so-
quit line.
So the number can be active, but you call, it routes you to your state and there's nothing.
That exactly, that could be the case. That could.
But if you're in Ohio and Ohio was no longer there, would it route you to another one or you just can't get it?
We don't know. They could ask for insurance information and bill it to insurance, TBD.
And then the other is, how do they determine state? Is it you're telling them or your phone number?
They know, I think you tell them and they must look at, but you know,
Some
still
people have out of state.
Yeah, so by your address, I imagine. Like if you go into like the current Ohio referral part, like where people can go in and refer other people to the quit line, the first question is, what state are you? This, I just took this snapshot yesterday because we've all heard what's going on federally and we don't, you know, it's hearing different things. So I think this is all stuff that can impact the multi-level contextual factors that we need to pay attention to. But to then wrap this up, this study, I'm excited by it. I'm also just very, it's a scary project because there's so many different elements that we want to keep track of, right? But we are thinking about sustainability and scalability from the outset. So the sustainability is without the research team being there. Scalability, the fact that I didn't say much about this, but we're working with the Greater Cleveland Food Bank uses a system called Pantry Track to keep track of households and every visit that they make to the food pantry in their network. And by embedding our questions into that, we'll be then able to link that information and even send the referrals directly to the quit line from that portal, fingers crossed. So it's a potential for kind of implementation model across the state and the country, and really kind of building on these existing resources with partnerships. Food pantries exist and there are many of them, and we're really building on that. And this is the end of my slide, right at the end of the hour. So thank you for being here, for your attention, to everybody on the research team. Here and then. Any questions in the minute or so? Yeah.
So you had the slide on SNAP funding being cut substantially. Does that affect this study in any way or the pantries that you're working with?
The SNAP, like this one, you mean
Yeah.
like the news? We, yes, it will, because for instance, like one of our design team members runs a food pantry, and today he said, you know, they've seen like a 25% increase in the number of people who visit with a lower allocation of the money that they can use to buy food for the pantry. So we're seeing that, and it will have ripple effects. And the fact that like they're sort of, the SNAP has been, the SNAP has been sort of uncertain for people, like, is it gonna end, is it gonna start, right? I also think about that from that uncertainty perspective. What is that gonna do to like people's coping mechanisms as well, when that's a source of stress that's now happening across the population? I didn't vet any of these articles, by the way, so if anything, looks like it's from like Breitbart or something. Well, thank you.
Thank you.
Sarah, I know you have to run out. Are you staying for class?
We're gonna go downstairs so we can